much. Actually, I should refer to WHO because that was the bit that inspired me to understand the real importance of health in all policies. So it is relevant to this because I was working on something called the Healthy Cities Project, and that was much more about embedding health into everything that cities did. And so it was very much the background to this sort of thinking. So thank you very much. I decided I won't apologise for being some something or other, and just want to talk about health and all policies. Just want to say a bit, and I'm including end equity. I just want to, we put in our little E sometimes in this as well, HiAP, just to remind everybody, because you can do health and all policies and you can miss and you can perpetuate or even exacerbate some of the inequalities that exist in our communities as well, and health outcomes. So I just want to say a little bit about why it's relevant to our work. Just saying how our sort of journey about understanding some of the aspects of HiAP, and a bit about our products and tools, and I'll just say a little bit then about the policy and practice and some examples that impact that we've come across in some of our work. So Dave didn't refer to this. This was one of the slides. We've taken it from King's Fund, so glad to be able to use that. And I think you are all aware that importance in public health of outcomes is that it's different ways of measuring it, but at maximum, healthcare, impacts about 43% of health outcomes, maybe less than that, and the rest is down to other social and economic and environmental conditions as well as health behaviours. So if we want to improve health and health outcomes and health inequalities, we need to focus on these things as much as on healthcare. And the public health system is monitored, guided by a whole series of health outcomes. You will all, I think most of you will be familiar with the public health outcomes framework, and it's across 4 domains, some of which are the determinants of health, some are about health behaviours, some are about prevention, and some are about sort of healthcare interventions. And so there are a range of those by which we can monitor our outcomes. And, for example, alcohol-related hospital admissions, we recognise the wide inequalities in these admission rates, with very big differences between some of the more deprived communities and the most affluent, even if it doesn't always relate to the alcohol consumption rates there. We recognise that, I'm sure Michael was referring to the best start in life, and we embraced that in PHE in terms of one of the most fundamental aspects of improving health outcomes. And school readiness is an important area that we monitor and measure and try to support, and I know you do that in most local government as well, is to say, how do we improve the chances of our children for getting ready for school. We're getting better, but we still see huge gaps as well between those in having free school meals and those who don't. So again, an inequality measure that we still haven't fully narrowed. It's getting narrower a little bit, but not as much as we would like. And just generally, overall, as a health system, we see this big gap between, we're having improvements in life expectancy, some improvements in healthy life expectancy, but the gap is widening. So we need to do more about narrowing that gap in terms of health expectation for people. So we want people to live longer but healthier lives as well. Economically as well, it seems to be an important thing. If we're going to have to work longer, is you need to be healthy to be able to work, and we need a workforce that's fit and able to support ourselves as well. So in terms of moving into health and all policies, we started on this a few years ago in terms of looking at it at PHE, and we looked outside the country as well to see what can we learn from elsewhere, and we also brought in some academic advice. Professor Mark Durs helped us to look at this and understand a lot more about what was happening across the globe. Plenty had been happening in some places, including support from WHO, a framework for country action, and we could look to some of the leaders such as Finland or South Australia, the state of South Australia, or the city of Seattle. And I think emerging from that were some of the steps one could take in terms of taking a systematic approach to health and all policies, which included setting your priorities and framing your actions, having the right structures and processes in place, assessment and engagement, and the monitoring, evaluation, reporting, and the capacity building. So that all sounds really appropriate, structured, and the right sort of things to be thinking about. But actually, some of the evidence in reviewing this across the world actually identified that in the real world, that actually this isn't always a simple thing to do. That actually policy processes, sometimes they're not linear, they're not even cyclical, and they're often messy and complex, and lots of different and conflicting requirements between different stakeholders and players, which can be anything about costs, about the needs of one group of stakeholders versus another, the right time and place in terms of the power and interests, and a different assessment of what are the trade-offs and costs and benefits, and again, for whom are the costs and whom are the benefits as well. So, and Fran Baum in Australia identified you can think about it in different ways. Sometimes when I talk to people, when we talk about health and all policies, we talk about can we have a health impact assessment of all the policies in government? And actually, that's not necessarily going to be the most effective or impactful thing you can do, because A, a lot of government departments on everything aren't going to necessarily accept that. And some places think of that as a bit of what's called health imperialism. So why would we focus on health versus other things as well? So there are some other strategies to be thinking about, which might be a win-win. See what are mutually beneficial strategies as well to take. If it's going to be about physical health and carbon emissions, how can we think about those joined up? Or, cooperate, you're helping other departments and they will help you in time. So again, this notion of cooperation rather than let's just shout loudly about health. And that seems to have worked in different places as well. Finally, sometimes we actually have to do damage limitation as well as a health and all policy, because policies can come through and some stakeholders some policies seem totally rational at the time, and then you may see the unintended consequences. We might think about our focus on roads and car transport from the sort of 70s onwards, and now looking at our sort of much more sedentary population, roads that don't help and enable local communities to take a lot of physical activity. And so on, how do we think about how we mitigate or reduce the impact of some policies as well? So all of this was informing us, and also thinking about, I was just wondering when Sally talked about the collaborative plumbing. I didn't know if this looked a little bit like collaborative plumbing, because she said, because this is about, this is what was described by Kingdon as it's a rather complicated title, but it's actually just looking at the windows of opportunity. So sometimes if you get the right alignment at the right time about identifying the problem and the politics are happening at the same time, you can just manage to get the policy in there just at that moment. So it's about being nimble and helping to shape and be responsive as well at that time. So if we think about effective implementation, we have to think of sort of hard tools, which might be health impact assessments and strong evidence-based documents, but also the softer dimensions of policy processes, which might be about leadership or create stakeholder engagement or the relationship building that needs to happen across different sectors. And when we talk about health and all policies, it might not be all policies at one time. It might just be specific thinking about specific public health issues, whether it's obesity or alcohol, or policy domains. Again, I mentioned transport or housing, a really important issue at the moment, and working with the relevant department or sector. Or, as I mentioned before, we can just look at those windows of opportunity when you can just grab those moments you've wanted to do something for some time, and now is the right moment to kind of go, great, we can do it at this point in time. So when we took all this on board, we worked with ADPH, the Associated Directors of Public Health, and the LGA to start running some masterclasses about this. And we also learned from that as well, and we realised if we were to plan some support for local areas, what would that be? And we sort of further evolved we started off with the Director of Public Health, but we expanded that, and worked with groups across the country in masterclasses, but also testing out materials with policymakers, chief executives of local authorities, and others who work on policy in local government. And we developed our resources based on that learning as well. And we don't call them health and all policies, we call them local wellbeing, local growth, because that was the message that was coming back to us, is that that speaks more readily to people working at local level. But we produced this range of materials, including a series of infographics you wanted to use to sort of illustrate and start talking about some of the subject areas on employment or mental health or housing and so on. And I'll give you the link later on. But my colleague Lina Toliakita, she's here in the audience if you want to talk to her later. She did the intensive work on this, so she's very happy to talk to you around those. So those are available on our website as well for use if, in different areas. And as you know, as I mentioned, our LGA partners also produced a whole manual for local government, so I would commend that to you as well. And we identified some of the examples of what's happening across the UK, and I know there are loads more as well, and we just need to be sharing more of the examples and the learning from some of these as well. I just want to move on to just 3 sort of case examples in terms of thinking, illustrating different dimensions of the challenge of thinking about health and all policies. And first of all, thinking about the alcohol and minimum unit pricing story, which I'm hoping a lot of you are familiar with the story around. One is about why minimum pricing is an important policy initiative that can help reduce the harm of really sort of high-strength, cheap alcohol at harmful levels. And it's also good for reducing the inequalities of the harm from alcohol as well. And Scotland embraced this, the Scottish Parliament embraced this in 2012, but it has taken up until just the end of sometime last year to go through a series of I suppose you call it one of the stakeholders in this, the challenges from the Scottish Whisky Association, who had to take it through the Scottish courts. They took it to the European Court of Justice, back to the Scottish courts again, because the European Court of Justice said go back to Scotland. And then when that didn't come up with the answer they wanted, it went to the Supreme Court as well. So you see the long journey it takes in terms of one, which might sound like quite a simple policy, to actually get to the place where Scottish Government can now start to implement this, and others are now looking at following that as well. My colleague Rosanna Connor was in the hot seat in the Health Select Committee just 2 weeks ago in terms of trying to bring across that message as well. Just to say something about school readiness, and I think this is a little bit about that message about finding the right opportunities as well. Our colleagues in our child health working on Best Start in Life had commissioned some work in terms of looking at speech and language and communication for young children, and had commissioned this work through working with the Early Intervention Foundation. And that identified the really important issue of speech and language, and children, it really is linked with strong, about language acquisition, the strong link between acquisition and life chances, and the links between that and children coming from disadvantaged backgrounds as well. So because of the working relationships our children's team had with the Department for Education over a number of years, we're in the right place at the right time to talk to our colleagues who are in the Department of Education to say, look, here's this really important piece of evidence. They were developing the Social Mobility Action Plan, and a chance for that to come together to say, actually, we do want a policy initiative that's around supporting children to acquire the best possible language skills so they are ready for school. And so we have funding to support developing a language assessment, and then simple more intensive interventions with parents. So it doesn't have to be specialist speech and language therapists, it's just simple interventions by which parents can learn how to do those simple communication messages, reading, supporting children to vocalize, and so on. So that was a moment, but as my colleague used to say, as he says, that took about 4 years of sort of relationship building as well, and having the evidence ready at the right time. And just sort of a third case example is relation to work we're doing in relation to planning. We've heard a lot about obesity, and one of the key issues that local authorities are trying to do is support how you have an environment in which can support particularly young children in terms of healthy eating. We've had the challenge of some local authorities were successful in being able to limit hot food takeaways near schools. Others found it a bit more challenging, even when they put it into supplementary planning documents. So some places, when they've had a legal challenge, often from some food industry, it hasn't always been easy to maintain the policy that the local authority has hoped for. And so we worked with department, well, there was the DCLG at the time, it's changed its title now, to further develop what's called the policy planning guidance for local authorities, and to support extra additional guidance in there that gave greater strength to what local authorities could do in terms of making decisions, and that is fed into people's local plan. And we were relieved recently to find that the inspector, when they reported on Redbridge's local plan, because every local plan has to go through the inspectorate, the planning inspectorate, and they quoted this change in policy as a part of the reasoning for allowing the new planning policy to restrict the hot food takeaways within 400 metres of schools. So that's just another little example about how you have to slowly work bit by bit with policies to try and make that bit of difference and navigate the complex multi-layered system out there to make policy changes that impact. So I'll just say in conclusion, just say that we do think that health and health equity in all policies has a really important role in improving health and reducing inequalities. It's not always possible to take a linear and stepwise systematic approach, but you probably know that in practice, but you have to sometimes you have to say it and repeat it, because it isn't that simple. But it has huge potential at national or at regional with our new combined authorities, or at local authority level, to improve health and to reduce health inequalities. So thank you.